Hey guys, my name is Mitchell Bourne, student here at NSU.MD and the president of the Emergency Medicine Interest Group. I'm joined today for a really cool interview. I have Dr. Emilio.Volz and Dr. Zagroba here. Both are emergency medicine physicians at Kendall Regional Medical Center. Dr. Volz is the program director and Dr. Zagroba is about to be third year resident, I believe. So if you guys could, we have a bunch of questions that were submitted to us by the members of our EMIG, both first year and second year, well, third year now, medical students. So to start off, if you guys could both just tell us a little bit about your background, like how you even got into medicine in the first place, and then what ultimately drew you to EM.
Sure, I'll go first. Hey, I'm Emilio.Volz. I'm the program director here at Kendall Regional. I know many of you already from our regular EMIG meetings. So my background and how I got into medicine really came when I was about 10 years old and maybe even younger. Both my mom and my grandfather were diagnosed with cancer. My grandfather passed away from colon cancer, and my mom had MEN type 2B, interestingly. So she's alive and well, but she went through several cancer treatments, and I was able to interact with several really excellent physicians when we were still living in Brazil. And that's how my pathway into medicine started. My interest began. But as far as emergency medicine went, I really wasn't sure I wanted to do emergency medicine until about the third year of medical school. When I had enrolled in medical school, I was gung-ho about general surgery. I wasn't even sure about emergency medicine as a career at that point. And I decided very quickly my third year that I wasn't going to be a surgeon because I didn't enjoy being in the OR. And the field was wide open for me. And during the beginning of my fourth year, so kind of late in the cycle, but I ended up doing an emergency medicine rotation at my home institution, which had no emergency medicine residency program. So I got to interact and spend a lot of hours with the EM doc there, who guided me into the process and kind of talked to me about emergency medicine, and the rest is history.
Awesome.
So mine, I guess, is a little different, just like everybody else's. I'm Sara Zagroba. I'm a second year resident at Kendall, about to be a third year, as well as about to be the chief resident for this incoming year. So I'm initially from New York. That's where I grew up. And I guess like my pathway to medicine started early on. I come from a huge family of physicians, so I definitely had that pool of people encouraging me to go into medicine. I was and then I guess early in college, I spoke to another female, and she really talked about her experience, and that encouraged me. I did some rotations as a pre-med student with OB-GYN and surgery following my aunt and my uncle. And I think I initially thought I was going to go into OB-GYN, to be honest, when I entered med school at University at Buffalo in New York as well. And there I really wanted to do OB-GYN. I think that kind of changed over time. I didn't want to be limited to just one gender and one specialty. So I kind of drew away from that. And then during my hardcore surgery, I actually put my surgery rotations at the end of my third year, where you're supposed to be at your peak. And I did 3 months of surgery. However, after doing 3 months of surgery, I did not like it at all. I didn't realize, I was being honest with myself, and I could not see myself in that specialty being on my feet. But there were components I liked. I liked the procedural component. So starting, I think I was late like you, Dr. Volz. I did a rotation in August, actually, because I studied for step 2 in July. And then in August, I did a rotation at my home institution, and I did a second rotation at my home institution in September with the specialty, mainly because it encompassed everything that I was having a hard time giving up from other specialties. It allowed me to do the OB-GYN, it allowed me to do the surgery, and it gave me the lifestyle that I wanted as an outside of medicine, where with surgery, I was going to, have to sacrifice that. So I'm super happy with my decision, and especially Kendall Regional.
Do you feel like EM kind of allowed you to blend in multiple specialties? Because it sounds like you almost felt you were giving up certain aspects of medicine with whether it be OBGYN or surgery versus EM kind of gave you a little bit of everything?
For sure. Like I still, I love OB-GYN. That's something I'm very passionate about, but, every day I get a female, whether it's in her teens or, her early 20s, coming in with either vaginal bleeding, pregnancy, and I get to deal with that, just like my colleagues who went into OB-GYN. And so I definitely didn't give up that aspect. OB-GYN rotation this year, and I was able to deliver babies, which I really loved. And, everybody dreads the pelvic exam now, but I still, enjoy doing that. And it's a different procedure, to just incorporate into my skill set. And just like OB-GYN, I'm able to do, I go into trauma bays and I do chest tubes, just like the surgery people. I'm able to do the basic, suturing, and just other, I'm able to be an anesthesiologist and intubate. It's such an amazing specialty that, I'm so happy I went into.
That's awesome. So it seems like you both kind of decided on the field way later on in your medical school journey. And like, I know there's only a few are pretty like sure this is what they want to do even earlier on in like first and second year. Would you give any advice to those that, like, who are in their first or second year and they, it's on their radar, but they're not entirely sure? Like, would you recommend shadowing or just trying to get like an early elective or anything beyond what you guys did yourself?
Sure, I'll start with this one. Yeah, I think the most important thing is to have exposure. And I think that's why I really like the concept that what Nova MD is doing of getting the medical student. I know COVID kind of put a hitch in our plans, but getting you guys some experience in the emergency department early on. Some of you have already shadowed with me. And the option is always there if you wanted to come in and do an evening or a night experience where we kind of just hang out and talk about emergency medicine. You kind of get to see the flow a little bit. But that's what I would recommend for those who are interested. Now, you remember, even, 7, 8, 10 years ago, that wasn't available for many of us. So the fact that you have now increased exposure earlier on, makes it a more available field for people to experience and choose it earlier on. It's not unusual that you would have students who are finishing their third year become interested in emergency medicine later in their medical student career because they just didn't know what it was all about. But I think many of us kind of felt like there was something missing, that they liked multiple things and they gravitated towards a general specialty versus some of the guys who ended up staying on and just really going gung-ho and just trying to focus on one thing. The mind of a generalist is different. We enjoy multiple aspects. We like to be available for a full spectrum of care, not just being confined to one particular field.
Okay. So both of you are going to have different perspectives on this, but like one of the questions was, could you tell us what the typically weekly schedule is like for a resident or an attending? And I know it's going to vary a lot, like based on the institution or even day by day, but maybe Dr. Zagroba could give her input and then you could.
Yeah, of course. So my schedule is never set in stone. So it's very hard to explain to, I guess, like colleagues and friends when they ask me like, oh, what's your schedule like this week? Yeah. It's, I'm going to say, this is my day off, my couple days off, because it's ever very changeable, like it changes constantly. So typically it's a 4-week block and the intending schedule mimics our 4-week block. We have about 18 shifts in a block and those shifts are about 10 hours. They range from morning 6 a.m. to 4 p.m., 2 to 12, and night shifts. So this week I was so fortunate and I scheduled 3 days off to go home. So I went home on Saturday, Sunday, Monday, Tuesday, and then I had conference on Wednesday. And then from conference, which typically every program has, which was from 7 to 12. Right after conference, I was the person that had to go into shift, which I worked from 1 to 7. And then I worked today from 2 to 12, Friday 2 to 12, Saturday and Sunday 2 to 12, and then I have 2 days off. But what I like most about my schedule is that, I put in my requests when I want to go home, I want to do things, and it's usually honored. And so it's not that I have these like every weekend off, but I pretty much get the time off when I want it, and it allows me for the morning to like do stuff or night shift, there's a lot of variability, but I like the variability.
Yeah, and even maybe I'm wrong, but even as a resident in EM, like the hours may be a little irregular, but at least the total number is a little bit less than maybe like surgery or other residents might have to deal with.
For sure. And then talking to my colleagues, I feel like my hours are less. They're more intense, obviously, but they are less. And I'm able to kind of make up time wherever I want, and be flexible in that sense and switch, which is nice to be able to switch with colleagues when something comes up last
Mhm.
minute. I think that's a big bonus.
And then how does that change pretty significantly when you're attending, I imagine?
So actually, it really doesn't change too much. Most of the attendings choose to do less hours than that. They choose to do about, you know, I'll say the equivalent of 12 to 13 shifts a month, but some of them choose to do more. Um, it really depends. That's the nice thing about EM, but it also can be a double-edged sword. You you can take more hours, but really with the variability in the shift times, it'll punish you if you try to do too much more than the 18. Some programs, some emergency medicine programs, they do 18 or 1912s. So it really is variable program to program. We decided to kind of strike a balance between giving you all time to study and
Mhm.
balance your private life and your personal life. And that was something that Dr. King and myself felt really strongly about. So as an attending, most of the time you're going to be working the equivalent of 12 eights, or maybe sometimes 12 12s per month, and 12 to 14. And then the rest of the time, it really depends on what you do. And then depending on your job, you may have certain limitations, like faculty have certain limitations of how many shifts they can work, program directors, APDs. Also, another thing that might factor into it is if you have administrative responsibilities within your emergency department. Sometimes the different sites, different jobs are going to buy down your time. So let's just say you did a fellowship in emergency ultrasound and you are the ultrasound director for your site. It Most of those guys tend to negotiate, okay, well, I'm willing to put in this many hours if you buy one of my shifts down. So they pay you for your administrative time.
Okay. Is it fair to say, like, for a normal attending, around 35 to 40 hours a week, just made up of probably 4 to 5 shifts a week? Is that fairly average?
Yeah, fairly so. Yeah, fairly
Okay.
so.
So kind of a different jump here. What do you wish you knew about EM before you actually got into this field? Is there anything that caught you off guard or something you just didn't know about?
Let Sarah answer that.
Way to put me on the spot. Something I didn't know about EM.
You wish you knew about before you got involved with the field? If not, that's fine.
Um, I guess like two little tidbits I would say I didn't know about is that we're basically an expert in every field. I know that's stating the obvious, but we're consulting a lot, but we gain all this knowledge from all these individual specialties. And then next time we kind of get more comfortable and more comfortable with specific procedures, whether it's draining a peritonsil abscess for the first time and then being able to do it on your own the next time. I don't know. So I guess like you really become like expert in a lot of different specialties. The second tidbit I would say, um, just really expressing interest in any specialty you're interested, specifically EM early, because I really feel like making those connections early goes a long way in the field of emergency medicine. I think that there's a tight network of people that really are supportive and encouraging, and you could do with emergency medicine afterwards. So whether that's with, FemIM, which is females in emergency medicine, or ultrasound, or sports medicine, or wilderness, event medicine, going to concerts and like being the doc there. There's so much you can do with emergency medicine. And I think the opportunities are endless, which is great.
So I'll add some stuff to that question. So when I first came into emergency medicine, I kind of had a less of an expectation than most. It was, it was kind of a last minute, you would say, decision for me, kind of late in the cycle. And it was after I did that rotation. So I didn't really kind of know 100% what to expect. But one of the things that attracted me to emergency medicine was the ability to be available when people needed you. So, the other field that I'm boarded in, as you know, Mitchell, is family medicine. So I did a combined program. And I'm always available to talk about the, contrast and compare combined versus categorical program. But the thing that surprised me about EM was how much I enjoyed the critical care component of it. And by that, I mean the acute critical care, being the person who gets to resuscitate somebody, being the person who has an acute intervention that saves somebody's life. The only way, or the only times you'll be able to do those things, as a family physician, is kind of rare. But even the other specialists, they're not there all the time. So if you're there and you're available, you get to do that, right? I mean, you get to be the first person to contact the patient who comes in CPR in progress, or tension pneumothorax, or something that needs acute intervention. That was one of the things that attracted me to it, and kind of kept me interested. The other thing that I was surprised about in emergency medicine was just how well organized the whole field, and how many bright minds there are in emergency medicine, and people that really inspire you. We have so many heroes in emergency medicine, I feel like, and people that we can like look up to and emulate. And also, I was really proud of ABEM, which is our emergency board certification. And I believe that it really does take a step above the other specialty boards, in the sense that ABEM provides really good psychometric data on people taking the exam, and really just has an organized curriculum for the specialty. If you're ever interested in looking at this, look at the milestones for emergency medicine, and look at the core content of emergency medicine that's available on the ABEM website. You'll see there's a lot of work that went into putting together our specialty by the pioneers of emergency medicine. It really shows.
Very cool. Just to go off one of the things you said, this is like further down the list, but I think it'd be a good transition to it now. I mean, obviously, emergency medicine is one of the youngest specialties. I think it's only a few decades old. Like, what excites you personally the most about the future of EM? Are there any like niches that you think may be really important in the future, or something that you want to get involved in, or just like where the future of EM is headed 5, 10, 20 years from now? I know the other day you and I were briefly discussing ECMO and how that might be like involved, but
Sure.
That's what came to my mind.
Yeah. Yeah, I think the future of EM is a bright future. There is, right now, and I think this fits some of the questions you may have further down the line, but there's we don't have enough emergency physicians to have a boarded emergency physician in every emergency department, right? That's a goal, right? Because you want people who come into the emergency department to get the best possible care, right? What's the future of EM? We're still kind of relatively in our infancy. As we kind of grow as a specialty and more people go into emergency medicine and move into these kind of smaller markets, I feel like the future of EM is going to be bright and brighter. I think there's new technologies that are going to expand our capability to do things for patients that we never seen before, like ED-ECMO is the topic that we were discussing last week. Right now, it's limited to a few ED-ECMO centers, but that's extracorporeal membrane oxygenation, which is a way in which you can, perhaps a new way or the future of doing CPR and bringing patients back. As we go into resuscitation research and pre-hospital medicine, we're kind of learning new things that we can do on that first hour of contact with a patient that is going to perhaps help us recover patients that we may have lost in the past. So I feel like EM is very much on the forefront of just general medical research. And honestly, in my opinion, medical research that matters, right? Because you're at the point of care, you're, introducing emergency ultrasound. Look at emergency ultrasound as an example of a technology that was brought forth. It existed for many years, right? People had been doing point of care ultrasound for many years before, family medicine docs, OBGYN docs, and then EM comes into contact with it, and our guys kind of turn it upside down and develop it and make it into, what you see as the point of care ultrasound revolution today. I feel like that's who we are as emergency physicians. We're a group of people that we're kind of like the MacGyvers of medicine. We're going to take whatever technology is available to us, and we're going to play with it and see how we can put it to the best use of our patients. And that's not to diminish preventive care. I obviously don't want to diminish that. As a family doc, I think, an ounce of prevention is worth a pound of cure, right? But if you're interested in being at the forefront of many of these development of these technologies in the application into resuscitation, there's really no better field for you to see those technologies being applied.
Yeah, I definitely think it's exciting to me, like, just because even with Dr. like, you're hitting so many different fields, like the most exciting 5 minutes of every specialty, as I say, like you're getting to see all these different aspects of medicine, and it's a lot of room for seeing something that could be improved and making some innovations, even as an ER doctor and some specialty that's not really yours. So we have a lot of questions about lifestyle type things and just like outside of medicine. So the first one was, do certain personality types fit best in EM, or does EM seem to attract certain personalities?
I've definitely heard that, person who's more like outdoorsy, adventurous, the ADHD profile fits perfectly in emergency. But I would say yes, but I would also say no, because just looking at my class of residents, the class that's below us, and the ones we just accepted for our incoming interns, there's so many different personalities. We're not all the same. We all bring a lot of back. Like there's some people who love outdoor activities and love going for runs, but then there's the people that are more quiet, and then there's the people who are love animals. We're all very different, but I think that what we all have in common is this passion for, emergency medicine, the adrenaline that comes with acute situation. I would say that.
Yeah, I think it's important too, because I feel like there's at least some students in every class that they kind of rule out EM automatically because they're like, oh, I'm not that intense, or I'm not like an extroverted person. But like there's such a wide, at least in my experience, I've met very introverted people and extroverted people and
For sure.
personalities in EM that are great at it. So somebody to feel like precluded from the specialty just because they're not XYZ type of person.
No,
and I feel like,
yeah, go ahead. I'm sorry.
I feel like every personality brings something different to the specialty.
Sure.
And I think that's super important. So the person that's more introverted, they're able to we need those people. We need those people to, they make people feel comfortable. People have different skills. We don't need those, like everybody needs to be loud, I think different personality types relate to patients differently. And I think that's important in emergency medicine, because in every specialty you see all different types of patients.
Yeah, I'll second what you're saying. I feel like emergency medicine isn't a specialty that's just for, certain type of personality. And I think you'll see when you rotate to different programs, when you get to talk to people from different programs, that every program has their own little feel. And, like tends to attract like, and, people who are alike tend to kind of cluster in a specific area or a specific program, because those are the people you interview, they have a certain attitude, and then that may jive with you or not. Definitely, I like what they call the tribe system, right? The tribes, when you find your tribe, you'll have a eureka moment. And that may be just you coming into contact with the people that it so happens that there are people like you that have, the congruent personality types on that service and may get you excited, or I could see myself doing this, or you see yourself in them. That definitely happened for me in emergency medicine. But, I could tell you from looking at our 3 classes, I agree with Sara, we have a wide variety of personalities. And you've got the MacGyvers out there and the people who are, who want to get in there and jump on the action. And then we have the cerebral guys who are more might say, medicine-y guys who are kind of just want to think about a problem. And each of them brings their own talents and their own kind of flair. And they all do an excellent job. You don't really need to have, it's not a requirement to be a specific way. I think the only requirement is to have a passion for acute care medicine, acute critical care. And, obviously, I think you have to be the guy the same way that, for me, I figured out I didn't want to be a surgeon because I hated being the OR. That would have been disastrous for me. So if you don't like being in those high stress situations and being kind of Johnny on the spot, ready to do what needs to be done, if that puts an undue amount of pressure on you and it makes you kind of hate your life, then don't do it, right? But as long as you're able to do the job, I don't think a specific personality is a requirement.
Yeah, I like what you said, just the underlying, everybody's passionate about acute care and emergency medicine, not so much they all the same, person. That's good. Are you able to maintain hobbies and non-EM pursuits throughout residency? And then what about as an attending? I guess it's more of like the work-life balance kind of questions.
Um, yeah, definitely. I think that I lost some of my hobbies during med school, just because there was always like that goal that I wanted to achieve, and I felt like I need to pour myself into studies. But I'm happier now in residency because, specifically in emergency medicine, it affords me that lifestyle that I was really looking forward to. So some things that I've done or I've been passionate about is like running half marathons. So I've run 2 in a row. And then just like hanging out with a social life with like my colleagues. I think that's super important, and being able to attend family events, because I'm really close with my family. So every time there's a holiday, I've been able to go home for like Christmas and Thanksgiving. Um, and if there's something going on, I've been able to do that. So those are things that are super important to me. And then specifically in medicine, we did a global health trip this past year, and so I was afforded the time to go to that on that trip, and it didn't really feel like work. It felt like a vacation to me, while I was still like practicing medicine, and it allowed me to explore and travel, which I'm also really passionate about. So honestly, EM has given me every opportunity been looking for.
That's good to hear. I mean, I feel like a lot of us, even like before med school, you're like, oh, when med school starts, you're not going to have any time for anything. And then when residency is going to be even worse. And like in reality, you just got to kind of adapt to what you're given and just, try to maintain those hobbies. So it's good to hear. And what about, how do you feel, Dr. Vols, as an attending?
Yeah, we were just talking about this earlier. I think COVID notwithstanding, right, which kind of, you and I have a similar mindset. We both like to grapple and do martial arts, and that has been interrupted. But I think emergency medicine is definitely a good specialty when it comes to lifestyle. That is what attracts some people to emergency medicine. It has its ups and downs, right? I mean, the up is you tend to work less hours, continuous hours than many of the other specialty colleagues, right? You can see the general surgeons a lot of times, the trauma surgeons, and you kind of wonder, man, their lives, it's pretty rough. I mean, obviously they find enjoyment and they find, you know, um, that they love their jobs as well, but that wouldn't have been a good fit for me, right? So and then you have, EM, and, what's the advantage? Yeah, you get to work less total hours, but the disadvantage is, you have a fair number of days, evenings, and nights, and you got to alternate between those, and you have to be able to find techniques to make those switches. And that's probably the most demanding thing on your schedule. Now, I'll never forget the day that I figured out, like, man, this is going to be great. Was All of us, our seniors, are about to graduate, went on our retreat for that year. And we were all Wednesday morning lounging in a beach in Southern Delaware and just chilling, and there was nobody else there. And that kind of, to me, illustrated the, why I think emergency medicine is a great specialty as far as schedule goes, is that you're off when everybody else is working. So you get to do whatever you need to do and get it done, which is kind of a sweet deal. So as far as switching back and forth, like which I mentioned is probably one of the challenges, it's mitigated by technique. Some people can do it well, other people can't. I personally don't use melatonin or other medications to try to switch. I simply plan ahead. And, if I know I'm going into a night cycle, I start turning into kind of night mode, and I stay up late, and I sleep in. And if I have to switch back into a daytime schedule, like for example, I worked Monday night into Tuesday, and then I had Wednesday morning conference, right? So, and I had to be there like awake because I had to lecture, right? So what do? I stayed up, I slept in, I took a nice nap in the late evening, and then I got up early. So I got enough hours of sleep and I was awake and able to function. And then I took a nap after conference. Like you can, as long as you're the kind of person that can do that, it won't give you too much trouble. The disadvantage is, when your kids go to school, like you may not be as available to do things in the weekends, right? Because you have to work the weekends. There are ways to mitigate that. And depending on your job, you may select a specific schedule. So one of the great examples of this is one of my favorite people in the world, Dr. Dorothy Dixon, who's an attending at Christiana. I believe she's still working clinically there. And she raised her kid on her own as a single mom. And she was our nocturnist doctor for years. And what did she do? She, took her kid to school, went home, slept when she was at school, woke up, picked her up from school, did homework, took care of everything, went to work. And she did that, I believe, 4 nights a week. And that's how she operated for years and years. And she was an excellent teacher and continues to be an excellent human being and teacher. So it's possible. You can mold your schedule, especially if you're willing to do things that other folks may not be willing to do, like be a nocturnist.
Yeah, it seems like it affords you a lot of flexibility, if anything, aside from emergency medicine being so cool. Kind of along with that, are EM physicians able to decrease overnight shifts if they choose as they get older? Is it like a seniority thing, or is it just going to vary a lot?
It varies a lot. It certainly varies a lot. What I'll say about that is some jobs will give seniority to people who are, over X age or who have specific circumstances. Most of the time, they won't make accommodations if you want to give up nights and just work days. That's most of the time, unless you're bringing something else to the table. And here's the importance of fellowship training, academics, and those kinds of things. I personally, though, believe that as a program leader, it's important for you to work night shifts. I think anyone in a leadership position needs to see what's going on at all times in the emergency department that you're helping to manage and the program that you're managing. So you can't be a frontline leader and say that you don't work nights. So I would say if that's kind of what you're thinking, like, oh, well, maybe I'll just be that guy that doesn't work nights. Well, hell, everyone's going to ask for that schedule. So expect that you'll work nights, If you go into EM, you'll work nights unless you get some very sweet deal.
Okay, so it should be expected then. So how do you, this is kind of similar to what you're saying, but like, how do you deal with burnout, or like, what is your perspective on burnout? I know there's been a lot of multiple specialties in burnout, especially EM. Any hot takes on that?
I know that I keep tagging a lot of these questions, but I want to answer this one because it's a topic that's very dear to me and near to me. And I do believe that burnout exists in all fields of medicine. I do not believe that burnout is higher in emergency physicians. I have several theories about this. Some people may disagree, and that's okay, and may point to some data out there. So I think you have to look at several things. The people who are choosing emergency medicine now are people who kind of got to do a rotation, when compared to years before. These are people that chose EM as a field. They kind of knew what they were signing up for. There are certain things that I believe is a formula for burnout in emergency medicine. And this is not universally true, but this is what I've seen in my experience. So number one, doing what I call a cash fellowship. Okay, a cash fellowship is when you finish your training and you decide to go out there and make as much money as possible in the least amount of time. And you sign up for like 20 shifts a month, and you decide that you're gonna, put in a bunch of hours to try to make as much money as possible. Yeah, not surprising that in a couple of years you're gonna burn out, and that happens to folks. How do you maintain a healthy lifestyle in emergency medicine? You maintain balance, you develop a niche, you can make sure that you keep yourself engaged outside of work, and you work an adequate number of hours to have a good lifestyle, but you don't go crazy on the hours. And we all know we all have debt, okay, and we all got to pay it back, but you don't want to be at the cost of your life. and your specialty and your future. So I do believe there is a component of myth to this, that emergency physicians are more likely to burn out than not. I think if you make an educated decision about your specialty and you know what you're heading into and you make some good decisions, you can definitely mitigate burnout. And like we said, it's a flexible schedule. So you are able to do things outside of work. Trust me, you're able to keep your hobbies. You're able to do all the things that you want to do, whether it be outdoor activities or whatnot.
Anything else to add, Dr. Zagroba, on that one?
Definitely we've had conversations about that in residency. For residency specific, we focus a lot on wellness and making sure that, we're staying healthy outside of medicine and dedicating some time off to specifically doing team bonding and just like enjoying. We'll do top golf, we'll have like beach gatherings, just time outside, just to kind of vent about what's going on, which I think is important, and to do other things and realize there's a life outside of medicine. And I think that's important in med school as well. You can get burnt out in med school. So it's just like focusing, like when you have time, making time of that and doing something that you enjoy. I think it's super important. For me specifically, I want to do a fellowship, and I think that finding something that you're personally interested in, having like something that you can do as a side hobby in emergency medicine, I think is and can help with burnout.
Just finding a niche.
Yeah.
Cool. All right, thank you. And then so obviously we've talked about how great emergency medicine is and everybody's super passionate about it. What personally frustrates you the most about EM, if you could at least pick one thing that maybe you could change, or just something that grinds your gears a little bit, whether it be patients or certain things you have to do that you don't like, or
Sure. Yeah, go ahead, Sarah. That's fine.
Okay. So mine, I guess, is like seeing like the drug seeking patients. Though I think that's like a common one for everybody. The patients that that lack the education, the understanding, and they're coming back after like a fourth visit. It can be really frustrating on me, and I think like my colleagues as well. We often say like, oh, what didn't you get before, but I think it's also special in the sense that if they didn't understand, I think that it's our problem to fix, and like actually sitting down to educate. It is time consuming and it is frustrating and it is exhausting, but it can be rewarding if it's done right. But that, I think, is one of my like biggest frustrations, is like someone who's come in 4 times in the same week for the same issue and nothing has really changed. That can be a little frustrating on me.
Sure. I think I agree with Sarah. I think, a lot of those really, if you look deep down into it, are our fault. And I feel like if a patient has an issue or that they didn't understand things, I think it goes back to what, we're doing right now, a course called the Teaching Fellowship. And I'm going to give a lecture on leadership next week to the second years that are about to be seniors. And that lecture on leadership talks about, something that I'm not sure if you'd like to read. Jocko Willink, he's a leadership expert, served in the SEALs and stuff. And I love reading his books. He talks about extreme ownership, right? You have to take ownership of the situation. So I think when it comes to the drug-seeking patients, you're gonna have to learn mitigation strategies, right, for how to deal with specific situations. And my way to deal with those patients is this: I assume everybody has goodwill and that they're here for a good reason, and I proceed with that assumption. I try to take my bias out of it. It's hard sometimes, especially when you know somebody well and they've been there 20 times before. But that's the day that's going to get you, right? That's the day that you're going to make a mistake, is when you minimize things and you push them aside and you say, look, you've been here 20 times for chest pain. I'm going to just discharge you now. And you always have to go back. It doesn't mean that you have to do a full workup every time, but you always have to think back, is my bias affecting the way that I deal with things? I think for me, probably the most frustrating thing about EM in general is we have great specialist colleagues that do give us excellent support. And I can think of so many off the top of my head. But every once in a while, we do run into somebody who's just unhappy that you're calling them at 3 a.m. and they don't fully understand what you're trying to convey to them. Dealing with those guys sometimes it probably is the one part of the job that I could do without. I think it would be nice to say, hey, look, thank God we have an emergency medicine physician that's willing to take care of our patients at 3 a.m. Every once in a while, he's going to need to call me. I'm on call and getting paid for this. And I know that many specialists feel like, yeah, of course, we'll fully support you. But there are some guys out there who give you that attitude of, why are you calling me at 3 a.m.? This isn't an emergency, and those kinds of things, which make it difficult sometimes. But again, there's also mitigation strategies for dealing with those situations, which is to, talk to your administration, maybe having a frank conversation with a colleague, and, involving your administration. But most of the people that you come across are excellent. And most of the time we have no problems getting patients admitted, getting patients discharged, getting patients follow-up, and getting patients seen. So most of the time it works well, but it is probably an area of frustration that kind of gets to me.
Okay, thank you. This is like further down the list, but you basically just touched on this. So maybe you both have different, takes on this. But what do you wish other specialties understood about your job that they may not fully understand?
I don't mind jumping in. And I know, Sara, you keep an eye on the clock, my friend, because I think you have a shift coming up in 8 minutes. Do you want to answer the question first and then head out?
Sure. So I would guess, for me, it would be like our time constraints. Like, I don't know. I feel like a lot of them are like, oh, like, why didn't you do this and this and this? Like, I am juggling like a lot of patients, I'm calling you because I don't feel necessarily comfortable. Can you come down and see, the patient,
Right.
I did this and this. A lot of them don't really want to come in unless you have like documented proof or, like for example, like an OB-GYN in unless you have the ultrasound documented in the system. So you could say like, oh, I reviewed the record, I looked at it myself, I really want you to come in, and I have to go see other patients, but they don't really understand that, they think that everything happens instantaneously, and that's not how it works in the department. Sometimes, we don't know, and sometimes, I don't know if that answered the question.
No, it does. Is it more of like a minority of the people that are actually frustrated that you're calling? Or are most people like, happy you're consulting them or not, or just thankful for the consult? Or is it more commonplace?
It's half and half. You get some people that are
Yeah.
super nice, want to and educate you. Even as an attending, I feel like I've seen that happen. And those are the people that I love referring out to in the end of the day when you have to say like, oh, follow up with GI, follow up with OB-GYN. But then there's those people that like, oh, they don't like to be called, and they give you a rough time and,
Before you even call them.
Yeah. Especially there's just certain specialties. But in the end of the day, I think that it gives you have to be a little more confident in what you know, and it makes you more point like when to refer to them. I think it's important knowing those specific things. But even in emergency medicine, we all help you. I just wish like our colleagues sometimes were a little more like that. But we do get the really nice ones who are like help us out for sure.
For sure.
On that note, I'm going to leave. So thank you for having me and good luck with emergency medicine. And I hope
Thank you so
we
much for
see
joining us.
this year.
Thanks for participating, Sara. I appreciate your time. Have a good shift.
Okay, bye.
So yeah, I'll field my version of that question. So what do I wish other specialties understood? And here, let me just lay this out, okay? Sometimes the specialist is right and we're wrong, okay? And that's not, so sometimes you make a phone call and some of those calls may be kind of a CYA quality, right? So you're kind of like, well, I just want to bring this person on board because I'm concerned X, Y, and Z. And, that does happen and that can be frustrating. So it's not like, we're all kind of the victims here and they're all kind of, bad guys. No, they're excellent people too. You also have to remember when you're talking to somebody on the phone, the same way that when you contact a patient, you don't know the background of the person's life. Maybe they're going through a divorce. Maybe they're having a bad day. Maybe someone close to them died. So it's not, it happens that these people have lives and you're waking them up and they have a case at 6 a.m., right? Those things happen. So, so what do I do personally to, what do I wish the other specialties understood? I would say this: understand that, at least personally, I don't want to wake you up in the middle of the night. I want to do the best that I can as an emergency physician and get things stabilized and managed. And I'm very conscientious of calling people. I don't call people that I don't need immediately, and I don't make CYA calls. Okay. So if you're a specialist and you happen to hear this, or if you're a learner, what are the things that you can do to kind of make things better? Contact your emergency physicians if you feel like there's a disconnect in what you're seeing, and come and do a lecture. Come and talk to us about what the issues are. And I know that most folks are going to be, especially in a residency program setting, are going to be more than happy to have folks come out and give a talk. That's always open to our specialty colleagues, and we've had that happen when we were giving neurosurgical calls, and the neurosurgeon came and talked to us and said, hey, look, call me for this, and I'm happy to come. I'm happy to take care of the patient, but don't call me for that. And it kind of helps. So there's always a conversation going on. Those conversations can always happen. So I think the same way that I assume goodwill on the patients and I assume goodwill on our colleagues, I wish that also everyone would assume goodwill towards the emergency physician and kind of work with us. And again, this is probably, we've talked too much about this issue. Really, it's not as big of an issue as you think. It's very rare to get a consultant who is unprofessional, but it does happen, and it is probably one of the problems that you have to deal with as an emergency physician, and you need to learn mitigation strategies for it. Same way that you need to learn mitigation strategies for changing shifts and those kinds of things.
Yeah, I think it probably comes up. I'm not sure, I'm only in my year now, but I feel like EM probably sends out a lot of consults compared to other specialties where maybe they're just doing most of the work, versus just the nature of EM. You have to kind of reach out to your specialist colleagues just to get their opinion or to admit them or whatever more often than others. So, okay, just a couple more questions here, and then we're going to switch over to residency director or residency directed questions, which is perfect for you. So how saturated is the field, if at all? And do you see that being an issue for, medical students going into the field that are going to be residents in a couple of years? Or do you think that's an issue?
Again, I personally don't feel like the field is saturated. Now, there are emergency physicians out there who feel that the field is saturated. So what are we talking about, and why there's a difference of opinion? Well, most people want to be in Miami, right? Most people want to be in the big population centers. So some of these areas may be saturated, right? So some of these areas that are high population areas, that are desirable places to live, are saturated. There's not enough ABIM boarded physicians to take care of patients in the rural areas. But that's where, supply and demand is going to come in. And we need to supply enough physicians to meet the needs of our patients. Eventually, the physicians that are all trying to stay in Miami are, maybe they'll make less money, maybe there'll be greater availability and not everyone can get jobs, and then they'll have to choose to go somewhere else. So how do you avoid that, right? You want to be the guy who wants to be in Miami. How do you swing that? I'd say right now it's probably not terribly hard, but in the future where maybe there's more graduates and stuff, well, you make yourself different. How do you make yourself different? How do you differentiate yourself? You get experience. Experience in what? It depends. It depends on what you love. It depends on what you want to do. If you're like me, you get experience in medical education and emergency ultrasound. Other folks may choose to get experience in administrative capabilities. Other folks may choose to get experience in EMS, or any subspecialty field, or maybe they have business experience. So there's a myriad of ways in which you can differentiate yourself. Maybe you get your MBA. There's different things that you can do to go a step above. But yeah, that is the truth. When there's competition, and when you have, Emilio next to, Mitchell, and we have the same exact credentials, who's going to get the job? The guy who differentiates himself. So work on those, presentation skills, how you present yourself, how you comport yourself during the interview, how you sell yourself. And that's going to be an important part of the field. The days of, folks just being desperate for ABIM boarded physicians and head over heels and stuff and trying to, do whatever they can to get you. Those days are probably going to be over at some point in the future when we train enough docs, and there's going to be greater competition. No question. Are salaries likely to go down in the future? I hope not, right? I mean, I like doing well. But if there's increased competition, they probably will go down some, and then there's going to be some happy medium, right? So, but I can tell you there's lots of open jobs. There's lots of job availabilities as of now. I get a job offer on email or on LinkedIn just about every day. I get recruiters contacting me nonstop to, go open a program X, go do, DIO position Y, go, be a chair here. And it just, most of the time I'm like, no, thanks. I want to stay in Miami. But I appreciate the offer. But those jobs are available. And so
Yeah.
are regular, clinical jobs.
So not saturated, just if your dream right out of residency is to be in a high, like Miami, Denver, some big population area, it might be kind of tough to get that perfect job unless you really separate yourself, is what I'm hearing.
Yeah, and coming from a program that can train you well, right? So, what do community jobs look for? They look for people who can effectively and efficiently see a volume of patients and take care of them, right? So that's when which program you're coming from matters. So if your program is, you're graduating and you're seeing one patient an hour, one and change, and that may not be the best number for you to put out there. If you have a program that's training you how to take care of high acuity patients effectively and efficiently, like Kendall, and you're highly competitive, let me tell you, our residents, I have a chief resident that matched into, or not didn't match into, but is pursuing an emergency ultrasound fellowship out of state. And she told me they point blank asked her during the interview, how many patients per hour she can see and those kinds of things.
Wow.
So it's becoming more common, right? So because that matters, right? Because how many patients you can see is, how much money the emergency department, the hospital will make, and that's gonna, make you a more, a more competitive candidate versus most.
For sure. Okay. That's a good transition into or like residency application directed question. I know some of us are only about a year and some change away from doing our away rotations and applying, so it's coming up pretty quick here. So one thing I've read that I've been a little confused about myself is seeing programs describe themselves as like county or academic, or there's probably even other terms I'm not aware of, but like, could you explain what those different style programs mean?
Sure. So there's really two ways to look at it. There's big academic programs that may be affiliated with a university, and then there's community-based programs that have an affiliation with a university, but they're really run by the hospital itself. And there's hybrids. There's hybrids from everywhere from 50-50 or a close affiliation versus the hospital is owned by the university, and those are going to give you different feels and different flares for the type of program. So very academic programs, so let me just say this: we're all academic programs, right? We all have the same ACGE requirements, but academic or university affiliated programs are going to do some things better, where community programs might do other things better. So it really depends on what you're trying to go into when you finish. So if you are somebody who is diehard, I want to be at X city and work at X university, then that would be somebody who I want to do, research and write a grant. Those are the kind of folks who may benefit from being at a program that has university affiliations with a high research output, and that can apply for those NIH grant studies, and who have all the machinery in the background to be able to get that done. So for whom is a community program better? I would say if your focus is, look, I want to be a community doc and I want to be the best community doc that I can be. And this is not universal, right? So some of these, what do you look for in a community program? You want a high acuity, high volume, and you want a program that's going to help you achieve the goal of being a good emergency physician who practices solid evidence-based medicine with a solid academic program, but who can also teach you and has the patient load and has the acuity to teach you to be efficient And I think that's one of the things that is really not focused on in many of the university programs, which is efficiency and patient volume and how to manage those well. I feel like there's probably a gap there where our focus is not only on excellent medical education, but also on producing quality community-based physicians. And the other thing to consider too is, well, I want to teach residents. Do I need to be in a big university program? That is not true. Obviously, it looks good if you come from a good university program and you're kind of transitioning into a community practice. It certainly is not going to be a detriment to you. But remember that most programs that are opening up are based off of community hospitals. So what does that mean? That means that there's plenty of residency programs available and plenty of academic positions available to where you don't have to necessarily come from one of the big name programs to match those. As a matter of fact, some of those programs are kind of have been there for a while, and they may be kind of not evolving as quickly as some of the newer programs who have younger faculty who are kind of have their finger on the pulse of academic EM and
Right.
can provide you kind of some of the latest and greatest.
Cool. Yeah, the next question was similar. What would you recommend looking for when choosing residencies to apply to? I think you touched on most of them. Unless you have anything else to add, it seems really like you should go somewhere kind of that emulates the environment in which you want to be in attending one day. Not necessarily like that's the environment you're going to be in, but it's going to kind of suit you best.
Yeah, I would say that the best program for you is going to have so personally, if I was back, in medical school and choosing a program, I would look for acuity, volume, and then I would look, probably geography is important to many folks. If geography is not an issue for you, then that's great. But for many folks, it is, because you're going to want the support systems and proximity to family and those things if you can have it. Fit within the program, right? Because I mean, you can be at, hoity-toity program and be, a well-recognized name out there. But if you dislike the people that you work with, you're not going to be happy, right? So fit is very important as well. So if you have a group of guys that you feel comfortable, or gals, or, a team that you feel comfortable working with, that's going to make all the difference, because, it is tough. Residency is it's a tough time in somebody's life. And if you don't have those relationships outside of work to help fuel your ability to have a good time outside the hospital, then that's going to make the whole thing miserable. So you definitely want good fit. You definitely want a good education with good volume, good acuity. And then when it comes to university and community, that's when really we all have to meet the same requirements. Kendall has 100% board passage rate. So it's really, many of our community programs do an excellent job. I train at a community program, Christiana, in Delaware. And I highly recommend you guys check them out. We came out strong. The Kendall residents come out strong. We take jobs sometimes where we kind of are more efficient and do better than some of the guys that come from university programs. That's not universal, but it really depends on what you're looking for outside after
sure.
residency.
We had a question about regional bias. Like, I know it's kind of similar when we are applying to medical schools, like where you actually want to end up practicing one day, but you kind of get in where you get in. And it's similar, I guess, with the match. I mean, you match where you match, even if you rank, your preferences. But is there a regional bias by residencies when selecting residents? And then on top of that, like if your goal is to practice in a certain area, should you really aim to be in a residency around that area?
Yes. So I'll say this. There is somewhat of a regional bias. So for example, if somebody were to apply to Kendall and they have clear ties to Miami and they're likely to stick around, that to me is a plus, right? Because I'm looking for folks that are going to contribute to the program later. That's the reason to have a residency program, right? That's one of the reasons that, the government funds these positions too. They want physicians that are going to stay locally and build up the practice of physicians in the area, right?
To know that state. Yeah.
So that's always a good thing. Now, does that limit you? No, we have folks coming from all over the country. To me, I would take more heavily, into account somebody's academics and their ability to perform well versus just wanting to be in Miami because I have family here. Okay, So it is a factor. It's a smaller factor than many of the other factors, like your step one, and your rotation letters and those things factor way more than geographics. Although I would be lying to you if I told you it wasn't a factor.
And then as far as, let's say that, for example, like your ultimate goal is to be an attending practice in California. Let's say you go to our school down here in Florida. Should you be trying to get into a residency out there, or is it okay if you maybe get into a great program like Christiana or something, but it's on the other side of the country? Is that going to hinder you at all, you think?
I think it will probably hinder you some. If you are dead set, so there are certain areas that are highly competitive, right? So California being one of them, right? I mean, California is they are kind of trending in a different direction in many of the programs around the country. Everywhere else in the country, we're looking at 4-year EM programs are pretty much kind of studying becoming a 3-year program because they know how damaging it makes them when they have to compete with other programs to be 4 years and everyone else is 3 years. California is making their more 4-year programs because they have such a huge number of applicants to look at, and they have so many classic, programs in emergency medicine that are very good, that they can afford to kind of be, more selective. So I would say to you this: if you are dead set in being in Southern California, or being in a highly competitive area, of course apply to
Try to go there.
that area and try to get in. It never hurts to know the players, right? So if you know the players, if you know the people that are there, they've seen you work clinically and they like you, then that's going to be way more advantageous than somebody trying to break in from the outside. Now let me tell you, I've got guys who graduated from residency who have broken into the system and work for Kaiser and work in San Diego. And so the jobs are there. It's not like it's impossible to go there.
It's just
But
going to be harder.
does it make it more likely to know everybody and to be there in the area already and kind of know the field? Yeah, of course.
Yeah, it's not impossible.
No, it's
Ignore
certainly
that.
not impossible. Very possible. It's very possible.
Yeah.
Yes.
Okay. More of a smaller question. Is it a downside if a program doesn't have an associated trauma center?
I would say yes. I think because here's it really goes down to just about every area that you see on a regular basis, right? So, how often does the emergency physician in the community see traumas? Well, they can see trauma anytime. So, doing a month at a trauma center, does it really prepare you for seeing traumas and having it woven into your clinical practice? No. Some things are rare, right? So, does it matter that you have a trauma center when it comes to doing chest tubes and a thoracotomy? Yeah, of course. When you're doing those emergent procedures in the trauma bay and you're doing them all the time because you're at a trauma center who takes all those trauma patients all the time, that's going to help you. So I think it's a big detractor for me. I personally would not want to train at a place that's not a trauma center. I'm not saying that they don't do a good job. I'm sure they do a good job in other ways. But if you don't have enough of that, acute trauma patient load, I would say that you're kind of behind the ball. Same thing with not having your own pediatric areas. So even at some community hospitals, even though you don't have a dedicated PZR, you still see a large number of pediatric patients. So, you'd want to have the pediatric experience kind of woven into it.
Okay. You touched on this a little bit earlier, 3 versus 4-year programs. I know it just depends on where you actually want to end up, but I feel like most people would tend to agree that a program is advantageous just because it's a year less. But at the same time, there's some fantastic 4-year programs out there, and maybe that, it does fit what you want. So do you have a quick take on whether one should preference one or the other, or should they not really worry about that?
It really depends on who you ask. It would be unfair. So I definitely don't want to speak to the detriment of my 4-year program colleagues. I think that they do offer a good educational experience. But my question, the point that I end up in my mind is always this: if I have Mitchell or Bob, and they're both applying for a job, one comes from a 3-year program, one comes from a 4-year program, do I view them as different? I mean, it's not gonna add a whole lot. They got an extra year experience. Okay, if all things were equal, maybe I'll pick Bob, who came from the 4-year program, maybe. But what if Mitchell did a fellowship? I would pick Mitchell every time.
Yeah.
Right? So does it add? So the extra year, what does it give you? It gives you a year of experience, maybe another research project and things. Does it help you get into a 4-year program as a attending? Absolutely. And as a matter of fact, they tend to protect themselves, right? So they tend to be like, you don't come from a 4-year program, so I don't know. So they tend to kind of protect
It's good to
themselves in
keep in
that
mind
way.
though, especially
Yeah,
if that
yeah.
is your goal.
Yeah, so I've seen that. I mean, I've applied for jobs, and I came from a 5-year residency program, right, where I did emergency and family medicine and a year of
Right.
fellowship. And I was told, well, we may have a job for you, but we have a couple of the 4-year grads. I'm like, okay, I'm sorry, I don't get that. So they do tend to protect their own, which is natural.
Sure.
So if you want to be in that specific site, do a 4-year program. If you want to be competitive for just about everywhere else, I would say do a 3-year program and a fellowship, or just go into practice and make money, in a healthy way.
Not a bad idea either. I meant to ask this when Dr. Zagroba was on. We hadn't got to it. What's the role of a chief resident? We hear about it. Why should it, and does it alter the timeline of your graduation at all?
So for most EM, I don't speak for all of them, but most EM programs do not make you do an extra chief year. I've never seen one that does. So EM chiefs are, at least in our program, and everyone does it a little bit differently. They are selected by their peers, and they become chief residents their 3rd year of residency, and they have administrative responsibilities. So what does that mean to be a chief? It means to be essentially a junior faculty member, someone who is interfacing and representing the residents to the faculty and the faculty to the residents. It's definitely a position that holds esteem and honor, and it's definitely looked very well upon when you're applying for a job. So you're talking about things that make your CV shine. If you get elected by your peers to be chief resident, that's kind of a big deal, and people love to hire chiefs. Why? Because they have administrative experience. They usually have personnel management skills, and they usually have good problem solving skills, and that's how they got the job in the first place. So what do the chiefs do? Well, they essentially help us manage the academic program. They help us manage the medical student rotation. They help us with the curriculum, and they give out. They tend to give. They are the mouthpiece of the faculty and of the residents. So from the faculty standpoint, if I have to roll out, let's just say, a new protocol, I tend to get the chief's input first. They kind of help me draw up a protocol, and then when there's approval, we kind of let them roll it out and take that leadership position within the department. The goal is to have the residents seen, heard, and represented, and having the residents have a say in the academic program. And most of the time, they can be the in-between, because sometimes people don't feel like they can criticize me directly, or they can say, listen, Volz, you're not doing this well, or hey, there's better ways we can do this. And I'm open to it. Like, I'm always, Mitchell knows, like, I'm like pretty down to earth, and people tell me, hey, Volz, you're messing up. I'll say, how can I lead you better? Clearly I failed you, right?
Right.
But not everyone's like that, and people don't feel like sometimes they can come up to me and say those things, and that's fine. They have the chiefs they can go through, and the chiefs represent those points to me, and they say, hey, look, there's concerns about X, Y, and Z. Can you do something about this? And then I'll have that information and be able to act on it.
Okay, awesome. So it's definitely a positive. I didn't realize, I thought that you had to take an extra year to do chief resident, but it's more of a positive leadership role, especially that your peers elect you. It's a pretty big honor.
For other specialties, it's different. Some of them
Yeah.
do, we don't.
Okay, it's good to know. Family medicine, EM as a combined program. Some people, I know a couple people in my class have expressed a little interest in doing like EM, IM potentially. Would you ever recommend doing one? I imagine yes, because you did it. And then if so, like, who should be the people looking into it versus just doing EM?
I'll give you the absolute honest truth here, which is, it's not for everybody. So would I recommend EMFM, EMIM, EMP, med peds, or, EMPs to everyone? No, it's a very, very specific niche of people who have that dual interest. Now, can it help you? Yes, it has helped me immensely to be an EMFM. I was able to get the jobs that I was able to get to off the bat likely because I chose to do fellowship and I had dual training. I was kind of able to further my career that way. That's not to say that it can't be done without doing that. But really it is about kind of developing your interests and seeing what you can do. Now, it's really hard for you to find a job for especially EMFM where you can truly do both and be in academics in both. You know, there's very few of those jobs in between. Most jobs that you come across are going to make you choose. Especially in academics, they're going to make you choose. They're going to say, because why am I paying you an academic stipend to work in another specialty? That's going to be the argument, right?
Right.
Unless they have that program. So for whom do I, again, and this is a very personal thing, and you should ask people that are in those specialties to like EMIM to kind of give you guidance. For whom do I think, so one, does it ever hurt? No, of course. People with more training are always welcome, and we always love to have them because they bring you a different perspective, so that's always good. It never hurts. Okay. But for whom is it right? I would say EMIM is probably right for somebody who either plans to split their practice between the inpatient or in the ER, or maybe EMFM for people who want to do outpatient and ER, or who want to be leaders in a program of that type. So, having the dual training becomes important if you're going to be a leader in one of those programs. People who want to pursue subspecialty training. So there are people that choose to do EM critical care. You don't have to do IM to do EM and critical care, but some folks choose to have that extra training. And certainly it makes you a more well-rounded person when you're applying, and it opens different things to you, like being able to do POM, which is not open to emergency physicians. Although, for my latest feel of the situation, most folks are choosing to not do POM and they just want to do the critical care. But if you wanted to have that experience, you can do that. There are some EM, IM crit programs out there too, which are interesting. So there are all sorts of folks that might fit the profile, and it's usually a select group of folks. Again, we talked about tribes. There's usually a kind of a fit thing, and some of those guys that are more medicine-y, they kind of fit in certain spots, and some guys that are interested in more outpatient general medicine tend to fit with the EMFM crew. It's just a different crew. And you kind of, if you're interested in exploring that further, you can always contact me. Mitchell can give you the contact. My contact information is free and available to anybody who wants to chat about it.
For sure. All right. Well, thank you for that. All right. Well, we've been on here for an hour, or a little over an hour, I think. Just finish with a few other questions, more tailored to the M2s, M3s that are, not too far away from applying. Especially with this whole step one, have you guys figured out a way to I guess you're going to have to alter your decision making with step one being pass fail. Is step two kind of becoming the new step one? Is that how it is for you guys, or are there other factors that are weighing more heavily now? Even for those of us that have already taken step one and have a grade, is step one going to be or step two going to be that much more important?
So I'll tell you how I feel about the whole step one, step two thing. I like to have step one as a numerical. I think it helps me make decisions about who's going to be a stronger candidate. I think step one has been correlated with board passage. So it's a good metric. I know what you guys want to hear. That it's pass fail, so it doesn't matter anymore. But what you're going to do by making step one pass fail and making step two a numerical thing is you're just going to put a bigger emphasis on step two.
Right.
Unfortunately,
It's still a
that's
numerical.
just what's going to happen. And it's still going to have a numerical value grade. Okay. Is there a difference between somebody who rocked their step and somebody who almost passed it? Yeah, probably there's a difference in study skills, and one guy's a little bit higher risk. Does it mean that person can't be trained up? No, it doesn't mean. But it does help you make a decision about, hey, which candidate, if you're trying to rank these 100 excellent people, who do you rank first, right? And people look at steps as one of the many factors. Now, somebody could have great steps, and I've seen this before, and I've seen it multiple times. Somebody has awesome steps, but they have a personality issue, and that comes across in their letters. That obviously bodes very poorly. Or you have somebody who has a borderline step, and they have excellent letters. Be like, oh, well, maybe they're just having a bad day, and that's, but they're excellent candidates otherwise.
Sure.
So, it's complicated. Obviously, I'm still going to look at just step one if I have the numbers available to me. I think if we're going to change it, we probably should change both tests. If we're going to truly make it a pass fail kind of thing, because it doesn't make sense to just change one of them. So hopefully that answers some of your questions. I think you should be, if I only had a pass fail step one, I personally, what I would do is I'm applying, because remember, you can change the test, but the guys making the decisions haven't changed. So,
Right.
Nor have we been like, come together as a consensus and say, we're not going to look at this. So if then I would personally, my advice would be take step two earlier and make sure you rock it, because that's going to be making the difference between you and somebody else, right? Because that's what we're looking for, right? You want the edge. Same thing when you're applying in for a job or you're applying for anything. You want to differentiate yourself. How do you do that? Well, if step one is all pass fail, then be the guy who took step two and rocked it. That's going to automatically be like, oh, well, of course he's a great student. Not only does he have excellent rotations, but he rocked step two. What about the other guy that didn't take step two yet? Well, we'll put him on hold for now because we got this guy great step two.
Yeah, I guess what I'm saying? The reality of the situation, especially for you guys, is if you have an objective measurement, you're not going to use it, so you might as well do the best you can.
Right.
Questions was, should you take step two before applying? I guess is more of a when should you take it, and does that vary between if your step one is like below average, or above average? Should that affect when you decide to take step two?
In current state, yes. So current state is we have a numerical step two, right? For your year, we have a numerical step two. So a step one, I'm sorry. So if we have a numerical step one, I would say, and you rocked it and you like kicked its butt, I would say you don't necessarily need step two before. Certainly you never need step two before applying for residency. So just apply to residency, okay? You get offered an interview and then you're trying to decide when to take step two. We interview people without step twos all the time, and their scores come in later, and then we kind of like make decisions later. So if you did well, hold off, right? I mean, hold off because, again, this is for my program. There are other programs who may be like, no, I don't interview anybody without a step two. I don't know those programs. I haven't talked to anybody who does this, but there could be programs out there who don't. So do your research of the programs you're looking for and see if step two is a requirement or not. I personally don't. I don't think Creatiana does. I know LSU doesn't. So the programs I've worked in before, they do not. They do not. So they do not require you to have it. So if you did it strongly, I would say hold off. There's no rush, because why risk being the person who trended down, right? Let's just say you did very well and then you trended down because you didn't have as much time to study. So take it whenever you feel like you can do well.
And the risk then would be, the risk of doing worse on number two would be, more so than the benefit of doing versus just not taking it.
It depends. So you certainly want to have it done towards the time people are ranking applicants, right? So if it's around the rank list time, you certainly want to have it done before then. So I would say it's probably less of a factor. So let me just say this. It's less of a factor for you if you did well. Just make sure you take it before it's too late in the season. So like mid-season, and make sure that you are actually studying well for the test so that you don't do poorly. And if you do a little bit less, nobody cares. But if you do significantly more poorly or poor on the test, then that may affect you. It may not, but it may affect you. If you did poorly on step one, that's when it really kind of can make it a difference, because there's a question now, right? The question is, I didn't do well on step one. And I'm looking at your application and I'm like, okay, well, Johnny has great rotations. He did well in everything, but his step one is poor. How do I know he can take a test and pass it? Or am I going to have to spend like hours and hours and extra training to try and bring this person up to speed? And the answer will be, well, did he take step two and do well? Because if you may answer that question for me and just say, oh yeah, of course. He brought it home for step two. We've had many of those conversations, be like, oh, well, look, you're a little below in step one. Okay. But look at their step two. Wow. They really brought it home. They figured out what they were wrong. To me, that's even reassuring, because it's like, wow, this person can learn. They saw what they did wrong in the first step, and then they did well in the second one.
Yeah, they took care of business on the second one. So for those of us that are going to third year, we have like a year of core rotations, and then we have electives basically for fourth year. People are wondering when you should do away rotations. and where you should choose to do away rotations, what you should look for, like, et cetera.
So certainly, and I know this COVID is changing everything, right? So you may be limited and stuff, and your
Hopefully
home,
next year it's not an issue.
right. But your home away, is important, because that's your trial run, right? You want to come, we are one of your home away locations, right? So come to me, and make us your first if possible, because especially if you really don't, you're like, look, I don't want to stay in Miami. I want to stay in Florida. I want to go out of state. So do an away rotation, or do a rotation here with us at home at Kendall, or Aventura, and just, learn as much as you can to sharpen your skills, and then do your second and maybe third rotation at the residency programs or locations that you really want to be at. So you still want to do a good job at your home away, because you want a great letter from me, right? You want me to say, hey, give me a great slow vols. And I'll always tell you, I'm always going to be honest with you. If I think that the letter that I'm going to give you is not favorable, I'll always tell you. That's why you always ask the question, be like, hey, you think you can favorably recommend me? That's a great way of asking it, being like, hey, did you like my performance? Are you going to write good things in my letter? Be like, absolutely, sure. We're happy to write the letter for you, and that favorably recommends you for a position.
Sure.
Awesome. So that's one thing. You kind of want to use the first rotation. Obviously you want to do well. You study before the rotation. You don't want to show up completely green, but it is your first rotation. Everyone understands it's early in the cycle, and you kind of want that first one to be not the throwaway. I don't want to use the term throwaway, but the one that you're using to practice for the one that you actually want. Now, if you really want to be at Kendall Aventura, which is great and awesome and encouraged, then maybe you do a rotation somewhere else that be kind of your throwaway if you have that many rotations available, and then come, swinging hard. Now, I can tell you, we've had people coming this year who were excellent, and there was their first rotation, but some of them were scribes before. They have previous ED experience. That always helps, right? Because you kind of know the flow of the department and those things, and they swung hard right away in the beginning. So it really depends. But usually it's a good idea to kind of get your feet wet first in the emergency department, learn how an EM presentation goes, how to, the flow of the department in general terms, and kind of get your feet wet before you go to the place that you really want a job from.
Okay. And then 2 more questions. I know we've been here for a while. I really appreciate it.
I'm happy to do it.
Yeah, it's been pretty great. Especially for the M1s, a lot of M1s do research over the summer between their. Do you recommend, if EM is on their radar? I know most of them haven't been like, EM is for me for sure. Should you do research in EM? Is research in EM specifically necessary, or is just, is research in general required or necessary to match to a good EM program?
I wouldn't say that research is required for you to match at a good EM program. Some programs may require some research. Ours does not. However, it's always looked well upon to have some research. So, if you can show me, it's like one of those, again, it's going back to, you have 2 guys, they're exactly the same. How do you make a decision between one or the other? Where does research fit in my list of priorities? If it's certainly lower than fit, certainly lower than steps, certainly lower than having great letters, but it definitely adds something, especially if you're the guy who knocked off like 3 or 4 research projects, right? If you're, having one is great, but if you're like, wow, this guy's interested in research, he's done research in emergency medicine, and he's got like 4 things he worked on. Wow, that's really impressive. And it kind of just, bumps you up. And you're like, well, this guy is going to come here and he's actually going to advance the field. That's awesome. We're always looking for those guys. We always want people who are interested in doing research. So so if you're an M1 and you want to do research in emergency medicine, and you want to do some work with us, definitely reach out. And we can get you hooked in with, projects that are either range from, we have a project talking about metallic foreign bodies in the eye, shoulder reductions. I have 2 projects going on relating to COVID-19 right now. And so that we can always get you in and get you hooked into those.
Yeah, as you know, me and my classmate Josh worked at Kendall over last summer between M1 and M2, and we had a really good experience with Dr. Zivik there. It was a good time. So definitely recommend it for the M1s. And then final question, just more geared towards us that are going into clinics for the first time or into clinicals. Any like words of advice or tips for any of us medical students, but just like how to really shine and do well in these like final few years to best set ourselves up for a residency of whatever specialty that may be?
Sure. I would say, come in with humility, number one, right? An open mind. Um, I would say to perform well, do your reading, show the attending that you are putting in the work. Don't, don't be a gunner, right? Don't try to backstab your fellow medical student colleagues. That always is looked poorly upon, right? Help each other out. You can get through this. It's not a zero-sum game. And if you do a tight presentation, so you're gonna learn very quickly what these are different fields, so they're all different, right? I mean, I went from internal medicine doc who wanted like an hour presentation on every patient to a surgeon who had me write a note that said no fever, patient okay for surgery, right? So and that was the note. So there's very different styles and different ways of doing things. So in
Might have lost you.
terms, what are the things that you should do? Hey, you still have me?
I lost you for a second. I think I'm back. Sorry.
Okay. No,
I heard no fever.
Yeah. So what are the things you should do in general terms? I would say you need to figure out what your attending wants and you need to deliver it. How would you do that? Ask for feedback. So day one, you get a patient, you do your presentation. Ask the residents. No, the residents will be your guide. And having friends with your residents means that they will make you shine. They can make you shine. So tell him, hey, look, how does he like to have that information presented? What does he want to hear? Does he want to hear all these labs? And then, you go and you kind of prepare your presentation, practice run, practice a few times, read about the case, understand the diagnoses before you talk about it, and just have a good time. I mean, it's really going to be a ton of learning. You can make it stressful if you want to, but there's really no need for it to be stressful. It's a wonderful learning environment. The guys want to teach you, you want to learn, so you get pimped, right? I mean, Mitchell and I, we get tapped out all the time, right? You go to the gym, you go and you get tapped out, and you get beat up, and then
Part of the process.
but you have fun. So it's okay. You will get tapped out. It will be embarrassing at some point, and somebody may call you out and be like, "Hey, I expected you to know this." Just say, "Yes, sir. I'll try to do better next time," and just rock and roll through it. It's okay. Put the ego aside. Ego is going to mess with you. It's just going to be a matter of you making yourself a better person by applying the things that you're learning. And if you come through a difficult situation or you're having a tough time, like I said, my information is available. You can always talk to me. You can always talk to the residents and get feedback. So not a problem.
Awesome, man. Be conscientious and stay humble and work hard, it sounds like.
Yep.
Well, Dr. Volz, it's always a pleasure talking with you. I really appreciate you taking the time, and same for Dr. Zagroba. I know she shift, but I really appreciate it. And I hope this was helpful to all the EMIC people and whoever else is watching this. It's been a great talk.
Yeah, I appreciate being able to talk to you guys, and I'm always available to help you out. Thank you.
Thanks a lot, man.